And first of all, thank you for having me for this presentation. So today I'll be talking about one of the studies that we did a couple of years ago. This was about a service delivery model for acupuncture for cancer-related pain and other symptoms in cancer survivors. So as you can see, the title here is Group versus Individual Acupuncture for Cancer Pain. So our main goal in this study was to determine the non-inferiority of group or community acupuncture compared to the individual acupuncture, which is basically the gold standard way of delivering acupuncture to cancer survivors. Okay. So this presentation would be subdivided into 3 segments. In the first segments, we'll be talking about non-inferiority trial that we did to compare individual versus the group acupuncture. The second section of the presentation deals with the cost effectiveness of group acupuncture compared to the individual acupuncture. And lastly, we briefly talk about the qualitative study that we also did to explore patient experiences of group acupuncture. So we'll get started with the first objective. So first of all, cancer-related pain. We all know cancer is a pain is a very common symptom among cancer patients, both in patients as well as in survivors, patients on active treatment and curative treatment. So, sometimes the pain can be debilitating. It can severely impact the patient's quality of life. It can interfere with their day-to-day functioning. And apart from that, patients also experience symptoms such as insomnia or low quality of life, low functional. So, and pain is the causative factor for most of these side effects as well. So it is pertinent that we address the pain issue in cancer patients. And because recently it has come to notice that a lot of cancer patients are report under treatment for cancer pain. And the mainstay treatment for cancer pain has been opioids for a long, long time, but they do come over their own set of side effects, such as nausea, vomiting, and sometimes they may also interfere with other medications that the cancer patients are on. And one of the major concerns that has recently come to light is about the opioid epidemic, especially in North America. So both clinicians and patients have their reservations to be 100% on opioids, and everyone has been looking for some supplementary treatment in addition to opioids, in addition to pharmacological treatment of pain. And acupuncture has been tried and tested as one of effective interventions for controlling cancer pain as well as other symptoms. So pain is definitely one of the major symptoms that acupuncture has been found to be effective for. And other symptoms are nausea, vomiting, insomnia, post-traumatic stress disorder, xerostomia. And these are the side effects of cancer treatment as well as the cancer symptoms. So acupuncture has been found to be effective against all of these symptoms. And as we all know, acupuncture is a therapeutic technique that is derived from the traditional Chinese medicine. And it is often used as a supplementary treatment alongside the conventional treatment. Basically, and the advantage of acupuncture is that it comes with very few side effects, and the adverse effects have been almost unheard of. And the standard model of delivery for acupuncture, especially in North America, is 1-to-1. So patients visit acupuncture clinic and they're treated on a 1-to-1 basis. But the disadvantage or the drawbacks of this is that it makes the treatment inaccessible for a lot of patients, especially because it's not covered under the universal health care, and patients have to pay out of pocket. And at times it has been noted that patients have to pay up to $75 to $100 for a single acupuncture session. So it phases out a lot of patients who cannot afford the treatment but still need it. At the same time, people who can still afford it, and we know that acupuncture is required by patients quite frequently. It's not because its effects are not very long term, so they need it quite often, sometimes even twice a week. So even if the costs are kept low, it makes the treatment more accessible to patients who need this treatment. So of late, some acupuncturists, some clinicians have tried this group acupuncture technique. And what this is, basically, it is a slightly different model to the standard delivery of acupuncture, which is on a 1-to-1 basis. In group acupuncture, the clinicians would have all the patients sit together in a big circle on reclining chairs, and then he would go one by one to each patient. And so in a certain amount of time, in a particular slot of time, they can treat multiple patients. So how this benefits is basically, first of all, it's less time consuming for the clinician. And at the same time, because multiple patients are being admitted and treated at the same time, so it makes the treatment more affordable for the patients. So, and some of the previous findings have shown that group acupuncture has been effective in treating certain symptoms. What is not known, and it has been effective in treating cancer pain as well. However, what is not known is that although apparently this is more cost effective, cheaper, more affordable, but does it provide the same level of efficacy as the individual acupuncture? So this question has been unexplored to date, and that is what we set out to do. So we wanted to determine if the group acupuncture would be non-inferior to individual acupuncture. And our outcomes were, primary outcome was cancer pain, and secondary outcomes were mood disorders, sleep, fatigue, and social support. We also wanted to determine if group acupuncture would be cost effective to individual acupuncture, and then also explore the qualitative experiences of patients who joined the group acupuncture sessions compared to the individual acupuncture. So coming on to the methods, study design. The first section was a randomized non-inferiority trial, and the inclusion criteria could be any cancer patient, male or female, over the age of 18 years, any kind of tumor group. So one of the main criteria was, because the primary outcome was pain, so the patients should have reported the worst pain score of 3 or above on a scale of 10, which is on the brief pain inventory scale. And the patients should have been willing to be randomized to either group acupuncture arm or the individual acupuncture arm. There were some of the exclusion criteria as well. For example, if the patients had received any acupuncture treatment within the previous 6 months, or they had stopped or changed the cancer treatment within the previous 6 weeks. So recruitment. So patients were mostly recruited from the Tom Baker Cancer Center. Most of the patients were referred by clinicians, cancer healthcare providers. But we also left some study brochures and study-related materials in the hallways at the hospital. So patients were allowed to self-refer as well. So when the patients showed interest, they came to the clinic with an interest to participate in the study. They were screened. Firstly, they were screened for eligibility based on our inclusion and exclusion criteria. Next, if they were found to be eligible, they had a one-to-one meeting with the acupuncturist. This was the initial assessment meeting to discuss their treatment plan. Because this being a pragmatic trial, we customized the treatment plan for everyone rather than having a standardized plan for every patient across both arms. And the patients were randomized into either group arm or the individual arm using block randomization, and was stratified by sex. So acupuncture procedure, as you can see here in this slide. So this is how individual acupuncture and a group acupuncture would look like. Individual is one-on-one, and group acupuncture, the patients are seated in a circle, widely spaced from each other. And they come in on a rolling basis. So they are usually given a 30-minute window to arrive. And, and then the total session goes about for 90 minutes, but each patient gets to stay in the session for about 45 minutes. They have the opportunity to talk as well. And one of the important concerns that a lot of audience have raised, and patients have raised this as well, whether group acupuncture is feasible in terms of how comfortable the patients are, exposing their skin in group. So for that matter, patients are not required to undress for this treatment. All they need to do is just roll up their sleeves of the shirt or roll up their pants. And that is where most of the points are located. So even if there was a mixed group, both males and females, there wasn't any reluctance to participate in the group acupuncture. So looking at some of the outcomes. So as I said earlier, the main outcome was pain, measured through the brief pain inventory. And the secondary outcomes were mood disorders, measured through the Profile of Mood States questionnaire, sleep, measured through the Pittsburgh Sleep Quality Index, fatigue, measured through the Functional Assessment of Cancer Therapy fatigue component, and then perceived social support measured through the inventory of socially supported behaviors, and the cost. Measuring patient and the cost aspect was looked at only from the patient perspective, not from the healthcare perspective. Next, so it was a non-inferiority trial. So non-inferiority margins to determine whether individual acupuncture is actually non-inferior to, whether group acupuncture is non-inferior to the individual acupuncture. And to determine that, we used linear mixed modeling to determine the changes from pre to post intervention scores across both arms. So this flowchart shows the recruitment and retention process. So we assessed about 226 patients for eligibility, of which 74 were found to be eligible and were randomized into the individual group or the individual arm or the group arm. So we had 39 patients in the individual arm and 35 patients in the group arm. So as you can see here, so both these groups received acupuncture sessions, and the average number of sessions completed in the individual arm was about 10 out of 12. And the average number of sessions completed in the group arm was about 9.4 out of 12. So there were total of 12 sessions over a period of 6 weeks, which means about 2 sessions per week. And we had about 32 of 39 completers in the individual arm and 23 out of 35 completers in the group arm, and who were assessed post-treatment. So this is a snapshot of how our patient population looked like. As you can see here, individual arm has 39 patients and group arm has 35 patients. Most of the patients across both arms were females, 77% in individual and 89% in group arm. And the mean age, we didn't stratify for age, so we observed stark differences in mean age in the individual versus the group arm. And very few of them were employed. Most of them were married or cohabitating. The patients were well educated, and most of them had a master's degree or at least a college degree, and the very least were high school educated. And again, in proportion to the kind of patients we had, like most of them were female. So as we can see here, the majority of the patients had breast cancer diagnosis in both arms, followed by GI cancer, gastrointestinal cancer, and gynecological cancers. Then we had few cases of hematological, lung, head and neck, and skin cancer as well. So this is how our participants look like. So now next step was to compare the change in pain interference and severity. So when we measured pain, we measured it through the brief pain inventory, which has 2 components of pain, the pain interference and severity. So pain severity is how debilitating the pain is, and pain interference is to what extent the pain interferes with your day-to-day functioning, day-to-day routine life. So we compared these pre and post scores through the linear mixed modeling across both arms. And as you can see here in the BPI interference scores, the red line here indicates the group arm. Sorry. The red line here indicates the group arm, and the blue line indicates individual arm. Although graphically you would notice that there is a bigger drop in the group arm when it comes to pain interference. However, this difference in the drop in the pain interference scores wasn't statistically significant. So we can say that the drop in pain interference scores was on par with each other for the group and the individual arm. Coming to the BPI severity scores, as we can see here again, the drop in the severity scores was also similar across both the individual and the group arm, and as it was not significant. So the BPI interference also has 2 further subcomponents, which is physical and psychological. So if we look here at the physical interference, BPI interference, the physical component, we can see here that again, the drop in the BPI interference physical scores was similar across both arms. It wasn't statistically significant. However, looking at the BPI interference psychological scores, we can see that there's a much bigger drop in the group arm compared to the individual arm, which was also statistically significant, which suggests that a BPI interference psychological component was better in the group arm compared to the individual arm. Okay. So now coming on to the non-inferiority analysis. So we've compared the drop in pain scores across both arms, and we found that they were on par with each other. But when it comes to determining the non-inferiority, whether group acupuncture was actually non-inferior to the individual acupuncture, so we had a special way of determining that. How we did that is basically first set a non-inferiority margin. So for the BPI interference scores, we determined, the literature, from literature search, we determined that a 1 point change on the BPI scale is the least score for to be a clinically meaningful change, and which is why the non-inferiority margin was set at 1. The reason you see it as -1 is because the score drops from pre to post intervention. So that's how we set our non-inferiority margin. Now, for the group acupuncture to be non-inferior to individual acupuncture, the requirement was that, so the 95% so the 95% confidence interval of the change scores between the two arms from pre to post intervention, we had to look at the non-inferiority margin in the context of this 95% confidence interval. And for the group acupuncture to be non-inferior, to be determined non-inferior, the lower arm of the 95% confidence interval had to be greater than the non-inferiority margin, which was true in this case. So we can see here the 95% confidence interval ranged from -0.15 to 2.28, and -0.15 was greater than -1. And so we could determine that the group acupuncture was non-inferior to the individual acupuncture. So coming on to the BPS severity. So we do not have any clinically established non-inferiority margins for BPS severity as well as for our other secondary outcomes. So we determined that those mathematically using a very standard process, which was 0.5 into pooled standard deviation of the raw change scores between the two arms. So it was a different value for every outcome that we evaluated. So for BPS severity, the non-inferiority margin was -0.81. And again, the same rule applied here as well. So the lower limit of the 95% confidence interval had to be greater than the non-inferiority margin. So again, as we can see here, -0.33, which is the lower end of 95% confidence interval, is greater than -0.81, determining that for BPI severity scores, the group acupuncture was non-inferior to the individual acupuncture. So we also determined the proportion of change in 1 point change and 3 point change in the pain scores across both arms. So as we can see here, for the pain interference, 1 point change in the individual arm, there was a 1 point change score happened in about 47% of the patients, and in group arm, it happened in about 65% of the patients. So subjectively, we can assess that there was a bigger proportion of group acupuncture patients who experienced a 1 point change in the pain score, although it was not significant. So the pain change score was more or less similar across both arms. But coming on to the 3 point change, patients who experienced a 3 point change on a scale of 10, so we can see here 9% experienced a 3 point change in the individual arm, whereas 35% experienced it in group arm. And the difference was statistically significant, again suggesting that in group arm, more people experience a bigger change in their pain scores. Coming on to pain severity, as we can see here, again, 1 point change was experienced by 66% of patients in the individual arm and 65% in the group arm. But again, it was not statistically significant. And if we look at the 3 point change scores, then we see 13% of patients in the individual arm experienced a 3 point change and 31% experienced a 3 point change in the group arm. But again, this wasn't statistically significant. So in terms of pain change scores, the proportion of people who experienced a 3 point change, both in the pain severity, was similar across the two arms. Now, we look at the secondary outcomes. So we adopted the same methods for determining non-inferiority of group versus individual acupuncture for sleep as well. And sleep was determined through the Pittsburgh Sleep Quality Index questionnaire. So again, the sleep quality to improve, the scores had to be, the post-intervention scores had to be lowered on the PSQI scores. So the same rule applies here as well. The lower end of the 95% confidence interval had to be greater than the non-inferiority margin, which was determined mathematically using the formula 0.5 into pooled standard deviation of the raw change scores across the two arms. And so it was determined to be non-inferior. Again, if you look at the graphical representation here, sorry, there's a bit of a discrepancy. So we can see there was a greater drop in the group arm compared to the individual arm. And interaction was significant. Now, we look at the mood disorders, which we determine through the profile of mood states questionnaire, total mood disorders. Again, we can see here the lower end of the 95% confidence interval is much greater than the non-inferiority margin. Again, suggesting that group acupuncture was non-inferior to the individual acupuncture. And again, there was a bigger drop in the change scores from the in the group acupuncture compared to the individual acupuncture. Now, fatigue. For fatigue, the trend reversed, because to notice any improvement in fatigue and perceived social support, the post-intervention scores had to be greater than the pre-intervention scores. So the determination of non-inferiority was kind of flipped. So here we see in this case, for the group acupuncture to be determined as non-inferior to individual acupuncture, we needed the non-inferiority margin to be greater than the upper limit of the 95% confidence interval. So here, as we can see here, the non-inferiority margin was 8.54, which is greater than 5.54, suggesting that the group acupuncture was non-inferior to individual acupuncture. And you can see here for the individual acupuncture, the change in fatigue scores are there's almost no change. But whereas for the group acupuncture, there was a substantial increase in their FACTF scores in the quality of life, which is statistically significant. And the last outcome that we looked at was the perceived social support measured through the inventory of social supportive behaviors. Again, to determine any meaningful change or change in the score, the post-intervention score had to be greater than the pre-intervention scores. So just as the fatigue measure, we needed the non-inferiority margin to be greater than the upper end of the 95% confidence interval of the raw change scores between the two arms, which was true in this case. So we could say that this was non-inferior to the individual acupuncture. And again, if you look at the change scores, there was a slight drop in the perceived social support in the individual, but in the group arm, the perceived social support increased dramatically. And we published this paper recently, earlier this year, and it can be accessed through this web link. It's an open access journal if you're interested in looking at the details. All right, so that ends the first section of the presentation, where we determined that group acupuncture was non-inferior to the individual acupuncture. On some of the outcomes, it was even superior to individual acupuncture, thus providing a solid evidence that group acupuncture for cancer-related pain could be an effective treatment, could be an effective delivery model. Now, when we know this, that the treatment is efficacious, it is non-inferior to the standard treatment, can be provided at a lower cost, is more affordable, can make the treatment more accessible, we wanted to formally determine the cost effectiveness of this treatment. So to determine that, we looked at the quality adjusted life years. So the objectives were to compare the pre and post intervention change in quality of life in cancer patients enrolled in either group arm or the individual arm, and then to assess the cost utility of group versus individual acupuncture from the patient perspective. So we use the EQ5D5L questionnaire for this to measure the quality of life. And it has 5 domains: mobility, self-care, usual activities, pain discomfort, and anxiety discomfort. So what it does, this is basically we calculate scores for all of these 5 domains. Each of these domains has 5 levels. And then we calculate a single utility score from this questionnaire. So there are almost over 3,000 possible combinations of health states that are possible. So we calculate a single health state using these 5 domains, scores from these 5 domains for each individual, and we assign a utility score to that. And the utility score basically varies between -1 to +1. +1 indicates a state of perfect health, 0 indicates a state of death, and -1 indicates the poorest imaginable health state, which is considered to be worse than death, and which is why it has been assigned the value lower than death. So this is the range of utility scores, and the utility index scores from EQ5D5L helps us to determine the quality adjusted life years as well. So this is a snapshot. This is how the EQ5D5L questionnaire looks like. We determine mobility, self-care, usual activities, pain discomfort, and anxiety discomfort. And the scale ranges from no problems to extreme problems. So each of these domains has 5 levels. So we determine the change in quality of life using the EQ5D5L over time across both arms using the linear mixed modeling effects. And the group size were also calculated using Cohen-D statistic. So what we determined, so the quality of life was estimated as the area under the health utility curve over time, which is basically a product of utility index derived from the EQ5D questionnaire and the time. So as you can see, and the time was basically 6 weeks. We wanted to determine any change in quality of life over a 6-week period from the start to the end of the intervention. And then this is how we calculated the change in the quality of life, measure across the 2 arms. And this time factor here was substituted by 0.125, which indicates 6 weeks of the entire year. And then we compared the mean quality values for the group and the individual arms using independent samples t-test. Results. The group acupuncture participants experienced a more significant relief in pain discomfort scale of the measure compared to the individual arm. So that suggests that there was a more significant improvement in pain in the group acupuncture compared to the individual acupuncture, the pain component of the EQ5D5L or the quality of life. All of the measures like self-care and anxiety, depression, and mobility or usual activities were similar across both the arms, the group and the individual arms. It was only the pain quality of life measure component that improved and had a greater improvement in the group arm. And if you look at the effect size, again, we can see here for the group arm, the effect size was 0.8, which is large, compared to the individual arm as 0.4, which is low to moderate. So not only was the change higher, but the magnitude of the change was also higher in the group arm compared to the individual arm. And but when we calculated the QALYs, the quality adjusted life years across both the arms, the group and the individual, you can see the values here. For the group arm, the QALY value was 0.02, and for the individual arm, the QALY value was 0.007. So we know that, we can see here that the quality adjusted life years, increment in quality adjusted life years was greater in the group arm compared to the individual arm. However, it wasn't statistically significant. So we can confidently say that, we can say with some confidence that the quality adjusted life years were similar across both group arms and individual arms. Now, this gives us, what does this suggest? The quality adjusted life years, which is the indicator of improvement in quality of life over a certain period of time, was better for the group acupuncture, was similar for both arms. However, group acupuncture, now we need to look at the cost. If the costs for group acupuncture are lower, then it definitely would be considered to be a superior treatment. But if the costs are also same, then perhaps they're both similar. Let's do the cost analysis here. So these are the costs from the patient perspective only. So there was no cost associated with the use of the hospital amenities. So basically, the acupuncturist fee was $50 an hour for both arms. And then there was an associated cost of needles and a cost of 30-minute assessment. And the cost of needles was also eliminated from this calculation because patients wouldn't have to pay for it. It would be included in the healthcare cost. So as we can see here, so the individual arm, the session went for about 45 minutes. The cost was about $37.50 per patient per session. For the group arm, the costs were calculated using the average number of patients divided by the hourly cost, divided by the acupuncturist fee. So that gave us the average hourly cost for each patient. And on an average, we had about 4 patients in each group. So the cost per participant per session for a group arm was about $18.75. And because although the participants stayed for about 90 minutes in the session, like the session went on for 90 minutes, but the total stay of the participant was about 45 minutes. And so this brings us to the total cost per participant for 6 weeks, which was about $375 for the individual arm and $176 for the group arm. And the cost of initial 30-minute assessment was similar. So what we can see here, so the total cost from the patient perspective for the entire program of 6 weeks was $400 for the individual arm and just about 50% of that for the group arm. So now we can, now what it suggests is basically the quality adjusted life years was same for both arms, but the costs are significantly lower, about 50% lower for the group arm compared to the individual arm. And we also did a sensitivity analysis because if we determine the acupuncturist fee to be $100 an hour, which is closer to the actual fee in the real world, so the cost of individual and group acupuncture would be about $75 and $37.50 per session. And the total cost over a 6-week initial assessment would be about 775 sessions for 10 sessions for the group arm and about 377 for the 9.4 average sessions for the individual arm. So we can still see here that, in a more realistic scenario, if we accounted for the actual acupuncturist fee, the total cost saving for about over a period of 6 weeks would be closer to $400. And for the same level of quality adjusted life years achieved. So in summary, group acupuncture was non-inferior compared to the individual acupuncture for pain. The group acupuncture exhibited greater improvement across sleep, distress, and fatigue. Group acupuncture was more cost-effective than the individual acupuncture. Sorry. And this paper is currently under review in the Journal of Alternative and Complementary Medicine, the cost-effectiveness paper. Now, last segment of this whole presentation is basically the qualitative study that we did to explore experiences. So in the interest of time, I've kept this section of the presentation very brief, just to give you the highlights of what we heard from patients who participated in both group and individual acupuncture. So the rationale was patient acceptability. Now we know that group acupuncture is non-inferior, and we also know that it is more cost effective, but we also wanted to determine the patient acceptability of the group acupuncture compared to the individual acupuncture, because this is a non-standard. I'm in a meeting. To compare patient experiences and acceptability of group versus individual acupuncture. So again, semi-structured interviews were conducted in about 11 people, and we selected people through purposive sampling to achieve diversity in age, sex, education, employment, cancer types, and treatment arms. And the data was analyzed using inductive thematic analysis or content analysis. So the major overall themes were classified into patient experience in the individual versus group arm and the clinical benefits achieved across both arms. So patients in both arms reported improvement in pain, quality of sleep, mood, fatigue for all participants regardless of the treatment arm. And participants across both arms also reported a good rapport with the clinician. So all participants regardless of the arm felt that they were able to establish a excellent rapport with the clinician. So there were some differences as well. For group acupuncture, patients reported a significant increase in perceived social support. There were some inhibitions among some participants. Some of them weren't willing to be randomized to the group arm. Initially, they had some reservations regarding, for example, they knew that these are all cancer patients, cancer survivors, so none of them would be ecstatic. A lot of them would be sad or depressed, and so if they joined the group acupuncture, they would be surrounded by other people who are also sad just like them, so that would not help with their mental health. So that was one concern. The other concern was privacy, or not being able to spend a good amount of time with the clinician. So these were some of the reservations. But at the end of it, when we explored their experience, they said, they felt more socially supported. They were able to talk to other people, other patients, share their experiences. So initially, there were some privacy-related concerns, but they waned over the period of time. In individual acupuncture arm, people really valued one-to-one sessions with the acupuncturist and valued the privacy that they were given, they were afforded in this session. And we also asked patients whether they would be willing to pursue private acupuncture treatment in future. And the cost was a factor for all participants across both arms, which again brings us to the conclusion that if cost is a factor for going for future private acupuncture sessions, then definitely group acupuncture would be more affordable. So these are some of the quotes. So participants, this first quote is from participant in the group arm, and the second one is from participants from an individual arm. So the one in the group arm says, overall to me, it's quite relaxing and comfortable in these settings. And I got acupuncture previously, years before. I have experienced something like good acupuncture and some bad acupuncture. Somewhere I've had good results and somewhere I had bad results, and found this is the first time I'm doing acupuncture that is good acupuncture. And this is coming from someone in the group arm. Similarly, a patient from individual arm said, I mean, it was well organized. Every session was perfectly on time. I'm not used to that kind of, usually I'm sitting in a waiting room just waiting for half a day, right? So I'm not used to that. So for me, it was like, wow, everything just happens where it's supposed to happen. This is incredible, right? So, I think it was good. I think the facility was good. Next, as I discussed a couple of seconds ago, so there were some apprehensions in some patients in the group arm. And they were like, I was actually kind of nervous about going into the group. I was a little nervous about that, little self-conscious. But no, it wasn't like that at all. And I had a sort of wanted to be in the individual arm, but in the end, I was glad I wasn't. And yes, I guess if I had to do it again, I wouldn't do individual, I'd do groups. So in terms of affordability, we had this quote from a patient in the group arm. Not everyone plans on spending if you're going twice a month and your cost is about $80 or $150 or $160 a month. And that's a lot of money to a lot of people. And then you may have to pick time off your work or have money for transportation or for parking. Having a cost too high could really make it impractical for a lot of people, especially if they're not working. So group acupuncture does make sense then in terms of affordability. And this paper, the qualitative paper, has been accepted in the journal BMC Complementary Medicine and Therapies. In conclusion, now this is a snapshot of the entire presentation. So group acupuncture is non-inferior to individual acupuncture in the treatment of cancer-related pain. It offers a more affordable treatment option for similar pain relief, similar quality of life increment. Group acupuncture offers similar experiences as individual acupuncture in the treatment of cancer-related pain, with no privacy-related issues, but with more social support. Findings have relevance for delivery of acupuncture treatments in resource-limited settings, where acupuncture is not included as part of universal healthcare. Patients have to pay out of pocket, and patients have to go for more frequent treatment sessions.
Great. Well, great way to end. Thank you again, Dr. Oberoi, for a wonderful presentation today. Really, really interesting. And I liked all the conversation and questions. And hope you can all join us again next month.
Thanks so much.